Let me welcome everyone again. Good morning, good afternoon, good evening. Thank you very much for joining us to this virtual Grand Round, a webinar co-organized by Lifebox, the University of Global Health Equity, and InciSioN. These are the three partners that are bringing you this webinar directly to you. We are meeting here today to talk about the disruption of COVID-19 on medical training in surgery anesthesia in sub-Saharan Africa and innovations for the future. As you know, COVID is a global pandemic with effects in day-to-day lives. As far as healthcare is concerned, academics, research, healthcare has been globally affected, and surgery is no different. Our panel of surgeons, anesthetists, and medical trainees and students will set out to discuss and provide solutions to their varying experiences of these COVID-related disruptions, particularly in surgery and anesthesia, and in training, service, and research. The panel will also evaluate the sustained impact of COVID-19 on surgery anesthesia training for the future, how curricula plan to address pandemic preparedness and response, how leaders and learners will adopt to the possibilities of delivering surgery and anesthesia teaching remotely, and how student research around surgery anesthesia will suffer or benefit in the wake of this pandemic. Today, we are very privileged to have renowned speakers to participate in this webinar. I would like to introduce the speakers now. And I'll start with myself. My name is Abebe. I'm an Ethiopian. I'm a general and thoracic surgeon, currently working as Dean of the School of Medicine at the University of Global Health Equity. I'm also joined by my co-chair, Dr. Robert Riviello, who is a surgeon and also the chair of the Department of Surgery at the University of Global Health Equity. He's a general surgeon with a practice in trauma, acute care surgery, and burns at Brigham and Women's Hospital in Boston, USA. He's an associate professor in surgery and in global health and social medicine at the Harvard Medical School in the program for global surgery and social change, PGSSC, and a fellow of COSEXA and the American College of Surgeons. Dr. Riviello recently joined the UGHE faculty. He served as the program director and for the Harvard contribution to the Rwanda Human Resources for Health HRH program. Our second panelist is Professor Catherine Chow, who is the director of the Center of Global Surgery and professor of global surgery in the Department of Global Health at the Stellenbosch University in South Africa. Professor Catherine received her undergraduate degree at Stanford University. She graduated from the University of California, San Francisco School of Medicine, where she also completed her general surgery residency. She is a colorectal surgeon, fellow at the La Haye Clinic, and then joined the JHU medical institution as a colorectal surgeon. She currently serves as Vice President of Medicine Sans Frontières, South Africa, and we are really glad to have her with us. The next panelist is Dr. Mahalet Tadesse, the President of the Ethiopian Society of Anesthesiology Professionals Association. Dr. Mahalet is an assistant professor and consultant anesthesiologist at the Tukur Anbessa Specialized Hospital in Addis Ababa, Ethiopia. She is also a cardiothoracic anesthesia fellow and the president of the Ethiopian Society of Anesthesiologists Professional Association. Our next panelist is Dr. Claire Karikaze, a consultant neurosurgeon at the Rwandan Medical Hospital. Dr. Karikaze is a consultant neurosurgeon. She graduated as an MD from the University of Rwanda and then graduated as a neurosurgeon in 2016 from the Mohammed V University, World Federation of Neurosurgical Societies, Rabat Training Center for African Neurosurgeons. I would also like to mention that Dr. Karikaze is the first female neurosurgeon to practice in Rwanda. Our next panelist is Dr. Marcella Ryan Coker, the advisor lead for InciSioN Sierra Leone and the surgical trainee. Dr. Marcella's background is in global health and development. Last September, she attended a course at Oxford University in global surgery. Over the last 2 years, through her training in low resource income setting, she has become more passionate about global surgery and the need for quality, accessible, and affordable surgery for all. And last but not least is Dr. Nelson Udme Abasi. Nelson is the chair of InciSioN Nigeria with 4 years of experience in student leadership, advocacy, initiatives, and volunteering. He has followed up on the trend of the coronavirus infection, mostly in neighboring West African countries, and has most recently collaborated and co-authored with fellow medical students in an international study on the reliability of YouTube videos as a quality source during COVID-19 in 6 languages. Please join me in welcoming the 6 great panelists to this webinar. I would also like to encourage all participants, all our viewers, to spread the word around. I would also like to encourage all audiences to share their thoughts through our Twitter handle @ughe.org. Feel free to ask any questions and feel free to type your questions through the chat box. Before we start, a little bit of housekeeping announcement. May I ask all participants to mute their microphones and if you have any questions, please feel free to type the questions or send us private messages. I will directly go to start the session. I would like to invite my co-chair, Dr. Reviello, to start the questions. Thank you.
Wonderful. Thank you, Prof. Abebe, and thank you to all the participants who've joined us in the webinar fashion. And I would like to especially thank our 5 panelists. We're going to go through a series of about 5 sections over the course of the next 40 minutes. And as Professor Abebe said, at the end we're hoping for a good 30 minutes of Q&A time. What that means at the front end, the panelists all know this, but for those who are coming in through the webinar, we're going to be very tight with our question and answer time, or our initial discussion. So either Prof. or Bebe will ask some opening questions, and each of the speakers will get 3 minutes. And then if we're going over, we will encourage you to finish quickly. So my first question goes to Dr. Marcella and to Nelson. I'd like to open this discussion by asking our student, Nelson, and our trainee, Dr. Marcella, for their experience on how this pandemic has disrupted, in some ways perhaps even compromised, your medical education and projects in surgery and anesthesia. So again, how has the pandemic disrupted or perhaps even compromised your education, your training, and the projects you're engaged in? Nelson, would you like to kick us off?
All right. Thank you, Dr. Robert Reviello. First of all, I will want to thank the University of Global Health Equity for giving I and invariably all medical students in sub-Saharan Africa to hear their views on how the pandemic has affected them. So first of all, I want to state that the pandemic has affected us in unique ways because there are certain circumstances, personal circumstances that makes the pandemic very unique to each medical student. So, but I'll just be hearing the general views now. The lockdown has stopped all clinical activities or ward rounds, classroom work, and every facet of the medical education system. So this is bad because these activities are where we get to learn about where surgical education and anesthesia education takes place through the ward rounds, through the clinic work and all that. So it has stopped medical education in all ramifications across all countries of the world. And this brings the issue of, it brings a conflicting issue here that should medical students be actually left out of medical education because of the pandemic, because we're going to be missing out from one of the most complex triage systems the world has ever faced. And on the other hand, we want to prevent infection. Medical students can serve as vectors, and they can also serve as source of infection to their colleagues and to their seniors in the management team, and to even patients and everyone that sets foot in the hospital. So aside from that, there has been cancellation prior to the lockdown. There has been cancellation of many examinations and assessments in many parts of sub-Saharan Africa. And my institution is no less one of them. Many cancellation, and this is very bad for mostly final year medical students because they will have reduced exposure to patients prior to their final examination. And of course, this will also mean that they're going to be graduating very late, as opposed to their colleagues in in the Americas or Europe that were that graduated earlier than was usual for them. So also, there's been cancellation of conferences. A very notable example is the IGSS 2020, which was supposed to be in Colombia. And conferences like these are places where global health leaders are being built, or where they learn and where they meet experts. I was fortunate enough last year to meet Professor Abebe, to meet Dr. Catherine Chu and Dr. Claire Karikaze. I think the pandemic affected us in this way. Even AMI 2020, where the Association of Medical Education in Europe, this is where there's an application for task force in that event, and medical students are a very core component of that task force. We are missing out from this. Another part is the mental health issues concerned with that. It has devastated the whole economy, and to feed for some people cannot go back home. Some parents are worried. So it has affected them in that way. And lastly, I want to mention that it will affect the choice in future. It will affect the choice of specialty for most medical students, because actually the surgical system is overwhelmed. Many people are, many of our teachers, surgeons, are now involved in taking care of COVID-19 patients. So many medical students might be reviewing, should I go into emergency medicine? Is it right? The burnout for anesthesiologists. It's kind of deplorable. So that is one way it has really affected us also. Lastly, before I go, it has also affected us in terms of meeting up with some requirements for our assessments, such as filling logbooks. Many medical schools in sub-Saharan Africa have what we call logbooks, and they use these logbooks are used to record the progress of medical students, mostly clinical medical students, in meeting up with certain tasks. And so in some climes or in Nigeria, if you don't meet up with some certain tasks on that logbook, you cannot write examination and you cannot do anything about it. So it is depriving us of the opportunity to fill in and meet some certain criteria for writing an examination. Well, there are some initiatives that have actually been coming up, but I think I will leave that later on. I'll make mention of that. So thank you very much, Dr. Robert. I think I need to leave the floor.
Nelson, wonderful. Thank you for all those comments. That last comment reminds me of a conversation I was having with a Nigerian surgeon about a week and a half ago, who has finished his training, but because of COVID, the hospital is essentially shut down, and so he's unable to continue collecting his data for his research to be able to present and sit for his WACS fellowship exams. Another way that the ability to get the criteria to be able to sit for your assessments is being held up. That was a great set of topics for us to think about. And let me pass to Dr. Marcella. What are your thoughts?
Thank you, Dr. Rubiello. So I think that we would all agree that surgical education and training in every part of the world has been affected by the pandemic. Sierra Leone is no different. And I try to ask my colleagues about their experiences as well, because I wanted to talk on behalf of all of us and our views. And from the many things that I gathered, we all agreed that because a lot of elective surgeries have been cancelled, this has been a problem for training. It has a significant impact on our clinical skills, our practical skills, our confidence, because we would all agree that surgery is more practical, is more hands-on. So the more cases we get, the more exposure we get, the more confident we become. But then with the cancellation of all these surgeries, we're losing skills. A lot of people have been reposted to lead the fight against COVID. And so, yeah, that is one way that this pandemic has affected surgical training. I will also say interactive activities such as morning briefings, handover meetings, tutorials, all these things used to be like very interactive and good for education and the academic bits, but we've had to put all of that on hold to maintain physical distancing. So we're losing out on that bit as well. And with residency programs too, I had a colleague that had to come back from Ghana because there had been some changes to their residency program, so she had to come back. So it's going to mean a delay in when they can take their membership exams and all of these things. And I think another problem is because the surgical workforce is so small in these parts, when one surgeon falls ill or dies, it creates a huge gap in training. So a lot of their trainees suffer, a lot of patients suffer, a lot of medical students, like Nelson mentioned, they lose out on skills that they should have gained from them. So I think that some lessons that Sierra Leone in particular could learn from this is to strengthen surgical capacity. Down here, we have less than one surgeon per 100,000 people. So imagine if one of those surgeons died. And like 2 weeks ago, we lost one of our surgeons. So it has a significant impact on the training. I think we should also think about investing in a lot in human resources and in technology as well, because maybe, just maybe, if we had some form of remote training and self-learning tutorials and things like that, we wouldn't lose completely. So yeah, it would be nice for us to think about ways going forward, how we can, what lessons we can learn from this pandemic and solutions. Thank you.
Thank you very much, Dr. Marcella. This is brilliant. We could see that the issues related to academics in research cuts across the entire continent, west, east, north, and south. Before I forward questions to the faculty now, may I remind all of us that this session is being recorded, and a copy of the video will be available to all of us within a few hours of the completion of the session. Let me now direct my questions to Professor Chow and Dr. Mahalet. You are both academic faculty in your own institutions with years of experience in teaching. How has the current situation affected you in your respective institutions, in your associations, in your day-to-day work? Let me start with Dr. Mahalet. Dr. Mahalet, you're probably muted.
Okay, I'm sorry. Now it's on now. Okay, thank you, Dr. Abebe. So I'll try to mention some of the challenges we're facing regarding COVID-19. So of course, 3 minutes will not be enough, but I'll try to highlight the most important challenge we're having. So first is we are having to stop the normal teaching activity because of physical distancing. So most of our teaching activities, which used to be like seminars, case discussions, journal clubs, M&Ms, and pre-anesthesia conferences, so all these things we had to stop with. So again, it brought a new opportunity, of course. So right now we are using virtual classes, we're using Zoom meetings to conduct most of our classes. We're using social media platforms like Telegram pages to conduct pre-op evaluations and to conduct the case discussions, to keep the case discussions ongoing in the department. So this is one big challenge we are facing. The other one is the crowded OR. So initially when the pandemic started in our country, the first response for most of the hospitals was to close the ORs. So at this time, there were no cases being done for like 2 to 3 weeks. So this had an impact because of course our residents were not getting enough case exposure. Of course, we used this we used this opportunity to get prepared for the COVID cases. So we ran simulation courses on PPE, donning and doffing, simulation on COVID intubation. We worked on forming protocols in mechanical ventilation intubation as such. Now we have reverted back to doing normal cases. So in my hospital, it's not a COVID designated center, so we are operating on non-COVID cases. But now what we are facing is the ORs are becoming very much crowded. So normally we're used to working in a very crowded OR because we have a large number of anesthesia residents, surgical residents, we have the nurse anesthesia students. So our ORs are very much crowded. So we significantly had to cut back on this. So again, this created loss in case exposure. Our residents, as part of their residency, they are involved in research, and because of this decrease in caseload, the research activities had to be disrupted somehow. The other big challenge we have was that we had to suspend visits from external faculty from our collaborating institutes. For example, in my hospital, we had a strong collaboration with Covet, the Canadian Anesthesiologists Society, which had been expanding over the past few years. Like right now, we used to have like 1 or 2 specialized anesthesiologists coming every month to teach our residents, to help out in the teaching. We used to run projects with them, like quality improvement projects. We started simulation training, we incorporated it into our curriculum, and we were running simulation twice a week. So all these things we had to suspend it because we had to stop our abroad visits. Again, on top of this, we had to cut back on our normal anesthesiology staff because we have to mobilize our anesthesiology consultant staffs to go and work on in the COVID center. So again, this is creating a very difficult decrement in the human power in the department. So it's compromising the teaching. Actually, later on, we might even be expected to mobilize the residents to go and work in the COVID centers, to work in the COVID ICUs. In Ethiopia, we don't have a lot of critical care physicians. So when our case number starts to increase, and if we have the surge we're expecting, then we will have to count on our residents to go and work unsupervised independently on the new COVID ICU. So again, this is also something we are preparing for. The other main thing, of course, is the health of our residents as well as our staff. Normally, as anesthesiologists, we're working in a very highly aerosol generating environment. We don't have enough PPEs like everywhere else in the world. So this is also creating a big challenge for us. Not only the risk of viral exposure, but also the mental health. Like there's a lot of panic, stress, anxiety, depression. So all these things, again, we have to address this. Another new thing we are facing is because of accidental exposure or probable exposure to COVID patients, we're having a situation where we have to cut back on the staff number and the residence number because of people having to go into self-isolation. So this is also, again, a big challenge we're facing, especially the residents. They live in, normally the residents housing in the hospital, they share a lot of common facilities like bathrooms and stuff. So if one person gets an exposure, then it's like the whole department might go into self-isolation. So again, this is also one thing we're worried about. The last thing I want to mention is the uncertainty in the newly starting residency program. So anesthesiology is pretty much a new field. It's a new expanding field in Ethiopia, and we're continuously trying to increase our number of residency teaching programs. So right now we have 3 programs running in the country. In the year 2021, we had planned on increasing 3 other institutes, but again, because of this COVID, because of the suspension with our collaborative institutes, and because of the different uncertainties, again, this is also creating a disruption in expanding our residency program as well.
Thank you, Dr. Mohamed. It's interesting you mentioned the mental and, in fact, physical illness among residents and trainees. This ties up beautifully with what one of our participants noted. Albert, he said, I have a sad feeling that young people will start to fear hospitals, and this medical career due to emerging diseases. Meet
Yes.
over lots of counseling in addition to incentives. I may be wrong though. I don't think you're right. You're wrong, Albert. I think you're absolutely right. This is a sentiment shared by almost all of us. Let me invite Professor Chow. Your views from South Africa.
Thank you, and greetings from Cape Town, which is, I think, the COVID center of Africa right now. But just want to say thank you to our co-chairs, our chairs, UGHE, Lifebox, and InciSioN for hosting this webinar, and it's great to be a part of it. So first of all, just to start out, I don't think anybody in this webinar needs convincing that sub-Saharan Africa needs a lot more surgeons and anesthesiologists, and COVID is really disrupting the pipeline of training. So specifically in South Africa, about half our trainees come from other sub-Saharan African countries because of the shortage of training programs in their own countries. And many of them have had to return home because South Africa instituted a lockdown at the end of March and encouraged most people to return home if they weren't from South Africa. And so some of the non-South African trainees have stayed, but quite a lot of them have had their training disrupted completely. And then to echo what Dr. Marcella mentioned about, we've had a massive reduction in elective cases here. We did a study recently of about 100 hospitals, and about 96% have canceled or reduced elective operations, which certainly means for the surgical trainees, a lot less cases, but a lot less variety in cases. And one specific example is there hasn't been that much laparoscopy training in Africa anyway, but the little that was happening has now been completely canceled out of the fear of the ability of COVID to spread through the decompression of the abdomen after desufflation. Now that may not pan out to be true, but at the moment, the small amount of laparoscopic surgery, which I think was very important for general surgery training, has gone to the wayside. Similarly in anesthesia, because as the previous speaker mentioned, it's a very high risk area with all the aerosolized COVID in the air. Most of the anesthesia training, the cases, only the most senior anesthesiologists are doing the intubating. So for sure, that means none of the interns or the junior residents in anesthesia are getting to do any of those cases. Perhaps they're relying on some of the more senior trainees, but again, that cuts down their cases. The next point is also just disruption in exit exams. So we have quite a lot of surgical registrars, anesthesia registrars that are finished with their training, and they were planning on sitting their exit exams, which includes an oral exam, and those have been canceled for this year. And so they are not able to graduate, and we're not able to continue the pipeline of further training. Similarly, some people are also had field research as part of their MEd requirements, and those also have been suspended. So all these people have been sort of suspended in their training. And then just to echo also about, here in South Africa, and I think in most of Africa, there's a real shortage of or capacity to test for COVID-19. So here in South Africa, in the public sector, our turnaround time is between 7 to 10 days. And so if one staff member becomes positive and the rest of the staff, for example, in theater, becomes persons under investigation, then everybody's out for about 2 weeks, and that really shuts down the theater. So several of our hospitals have already been incapacitated in terms of theater, which certainly affects training. And I'll just stop there for now.
Thanks, Prof. Catherine. Let me take us from there to our third question, and this question is for Dr. Claire and Dr. Mahelet again. I want us to think about looking at the current climate of surgery and anesthesia in sub-Saharan Africa, which we've discussed a bit in the previous responses. What would you say are the most critical skills academic institutions need to be building for their trainees for long-term investment in future surgical capacity? Or for Dr. Claire, you might want to address what are the critical skills and systems and structures that hospitals and healthcare delivery institutions need to think about as we look forward from this time many places are starting to think about return to whatever is our new normal. So I'd love to hear your thoughts on these two. Dr. Claire, do you want to go first?
Yeah, thanks, Rob. It's a pleasure being here, also being on this webinar with everyone. So I'll talk a little bit about our experience here in Rwanda. I work at the military hospital, as you said in the introduction. There also surgery was disrupted by the COVID-19 crisis. So it has been a bit of a surprise for everyone to, to have all our gaps in healthcare systems worldwide, whether it's in Europe, it's in the US, or even in Africa, revealed this way. I know we have been in this global surgery movement, pushing for global surgery, pushing for having more equipment, pushing for having more surgical services more developed in low and middle income countries. But with the pandemic, it's like everything was, exposed, and we're just exposed to the reality. So in my experience, as a new faculty, having less surgeries was also a problem, and still a problem, because we had to cancel most elective surgeries, and we had to keep doing emergent surgeries. And most emergent surgeries we do are trauma cases, and we have seen a clear decrease in trauma cases because of the movement restriction. Of course, we did not have, all those motor accidents and all the road traffic accidents. So we saw a clear decrease in flow of those cases, but we also seen all the other cases, like the cancer cases, tumor cases, infectious. So it brings me to think that we need a robust healthcare system. We need to build up our system. It's so unfortunate that it had to take a pandemic to see all these gaps, but we need to invest in the 4S, as Professor Pofama says. We need to have, it's not only building capacity, but we need to have reliable equipment. Everyone was thinking what happens when COVID comes to Africa. So as we have low capacity in testing, low capacity in treating, low rate of ventilators, and few anesthesiologists, of course, and critical care doctors. So I think we need to invest in that capacity building, but we'll have also to have those staff, as in having equipment, ventilators, or other surgical equipment that are needed to build our strong healthcare systems. But we'll also have to bring our system to follow and to understand those needs that are really so important in building sustainable healthcare systems worldwide. So so that's how I see it. I see it's not a good way, but the pandemic revealed these gaps, and then we need to respond to those gaps. It's not only teaching, but it was also all these other activities that we're doing and we were improving that have stopped for a while. So what do we do when we go back to the new normal? Are we going to keep pushing for surgical services, or are they going to be forgotten? That's my worry a little bit. I hope everything is going to go in that line of building a comprehensive healthcare system. Thanks.
Thank you, Dr. Claire. It makes me think, before we go to Dr. Mahalit, I'm in Massachusetts in the US right now, a landmass, and it's very similar to Rwanda with about half the number of people in it. Rwanda's had 1 or 2, maybe 300 cases known and no deaths to my understanding. In Massachusetts, we've had about 130,000 cases of COVID and over 6,000 deaths. And the halt that you described, that Dr. Catherine described, to surgical services sounds the same as what has happened here where I'm standing, of stopping all elective surgery for the right reasons and only doing urgent and emergent cases, a decrease in trauma cases, even a decrease in urgent non-trauma cases, they're just fewer. But the impact of the stopping training for much smaller viral caseload is striking. So thank you for that pause to say, or those reflections on now that we're pausing, how can we improve and never waste a crisis is a statement. I think that's what we're here to do, is not waste this crisis. Dr. Mahalat, it would be interesting your thoughts on the way forward in academics.
Okay, thank you. So just like everywhere else in the sub-Saharan country, again, surgical capacity in Ethiopia is very much underdeveloped. So just to mention the figure I got from, it was around 2 or 3 years back, it showed like we had around 200,000 surgeries being done in a year, but the unmet need for surgical cases was around 5 million surgeries. And the waiting time is normally like 2 to 4 years, and for some specialties, it's even more than that. So on top of this state of surgical capacity we now have COVID. So this has set us back a lot. We have stopped most of our elective cases. So definitely our waiting time is going to be even much more extended. But one opportunity that this pandemic presented is that it showed that how underdeveloped our health systems really are. So I think we can use this opportunity to demand more equipments, more everything for our hospitals. And I'm sure even after the pandemic is over, it would leave us with at least somehow a better state of our hospitals. So we're not only worried about the hospital setup, but we also have to work about expanding the human power. So for Ethiopia, for example, 110 million population, the number of anesthesiologists is still very, like, if you count the Ethiopians only, it's like 60, 61. If we include the expats, maybe it might go up to 80 otherwise. That's for a population of 110 million. So definitely we have to work on our human power. And one of the ways we have to approach this is we have to expand our teaching institutes, but not only focus on quantity, but we also have to focus on quality. So as a society, we've been working on maintaining quality to the newly emerging residency programs. We have, with the Ministry of Health in collaboration, we've produced a harmonized curriculum. We've put standards in place, and also we've trying to modify the way we are teaching our residents. So when we're teaching our residents, not only do we want to impart them with the proper knowledge and skills, but we need to work on their non-technical skills. So work on their leadership, communication, because at the end of 3 years of their residency, we expect them to go and start a new department, become department heads, start a new teaching program. So while they're residents with us, we have to work on their teaching skill and all the other non-technical skills, and make them prepared for their future. And we also have to continue our close relationship with them even after they graduate. So maintaining platforms where we can discuss cases with them, maintaining a platform where we can coach them, trying to create collaborations with the new institutes and involve them in trainings, and as much as possible trying to work not only on the big teaching institutes, but also on the newly emerging institutes, and expand our human power.
Thank you so much, Dr. Mahalet. You brought out a very prevalent problem in Africa. I would just like to read a few sentences from a recent publication at the British Journal of Surgery. Just 3 sentences. The researchers estimate that 28.4 million operations would be cancelled or postponed during the peak 12 weeks of disruption due to COVID-19. And in their conclusion, they said, if countries increase their normal surgical volume by 20% post-pandemic, it would take a median 45 weeks to clear the backlog of operations resulting from COVID-19 disruption. So take this in the context of an existing backlog of between 2 to 4 years, plus additional 46 to 50 weeks, just because of COVID. So we are faced with a big global challenge. Ladies and gentlemen, you're tuned to a webinar co-hosted by University of Global Health Equity, Lifebox Foundation, and InciSioN. We are joined by 6 great panelists. Myself and Dr. Robert Rivello are chairing the session. Now I'd like to direct the questions to Dr. Chow and Marcella. We have established that COVID has affected the way academics is going on in the region and how it has affected research. Now, I'll be interested to also hear about pandemic disruption to research and education around research, as well as how COVID-19 will pose new directions for routine and clinical research going forward. I would like to start with Professor Chow.
Thank you, Professor Bekele. So, I mean, I think as we had mentioned before, I had mentioned, so almost all field work has stopped. And, you know, that has affected quite a lot of our work, especially looking into sort of qualitative research into barriers to access to care. And it has really disrupted the ability for international academic collaborations, which has been so important in global surgery, to be able to have meetings like InciSioN, to be able to work with our international colleagues to come and teach, for example. I know at UGHE, you've also been affected by that. But as Dr. Rivello and as Winston Churchill said, never let a good crisis go to waste. I think there are opportunities for research even around this pandemic. And I think the first thing is that, you know, how does COVID affect surgical patients, postoperatively, intraoperatively? And there's some international data coming out. I think there's a paper coming out in Lancet next week to suggest that COVID patients do really poorly postoperatively. And I think that that's something, you know, in our setting really to investigate, because our patients are a different population than perhaps in Europe and North America. They're younger, they might have different conditions, different comorbidities. And there's an opportunity to join international collaboration. So there's a collaboration going on now called COVID Surge that's being run out of the University of Birmingham, the same group that published that article in the BJS, Professor Bekele, where institutions around the world can enter or to enroll their patients who are preoperatively COVID positive or discovered to be COVID positive postoperatively, but they're looking at 30-day outcomes. And I think that's a great opportunity for sub-Saharan African hospitals to also participate in a study like this to show what are our outcomes in these kind of patients. The second thing is that, you know, here in a study in South Africa, about 50% of postoperative routine care has been canceled. So patients are asked not to come back to the clinic. And there's been some effort to phone them or to video conferencing. And so, you know, there are possibilities to try to reach out to patients using telemedicine, you know, mobile health apps to contact them. And I think this is a great time and area that we can also invest in sort of new technology and implementation science around that. Secondly, you know, the movement of patients between hospitals has also been discouraged and limited. For example, in the Western Cape here in Cape, and in particular in Cape Town, we have a lot of cases, but we receive a lot of cases from other provinces like the Eastern Cape and in the rural areas. But because of so much COVID here, those hospitals are reluctant to transfer their patients, and for good reason. So the ability to co-manage patients with them, so perhaps specialists at an academic or tertiary hospital giving advice on the phone, through an app, through telemedicine, to the doctors at the district hospitals and the secondary level hospitals is something that's really pressing now, something that we've always encouraged in the global surgery's push to improve access to care at the decentralized level, but now even more so. I think it's very important. So I think there's new areas of research coming up around that. And then finally, just what I was saying about how a lot of academic global surgery, you know, a lot of that momentum seems to have been broken because of COVID. I think actually this is an opportunity, for example, like this webinar, of finding new ways to meet rather than always needing to convene in Kigali for the InciSioN 2019 or in Colombia for InciSioN 2020. You know, it is always nice to meet young folks like Dr. Nelson in person, but I think that international collaboration still must go on, and I think this webinar is a wonderful example of it. So I'll stop there. Thank you.
Thank you, Catherine. Dr. Marcella, your views?
Thank you, Professor. As Dr. Catherine has said already, there have been a lot of changes to how surgeries are done and hospital settings in general. And this has a lot of impact for surgery research and research around surgical training. I think personally that because of these changes, it's really difficult to have optimal results for research, and these limitations may induce biases to studies and things like that. So down here, there are a few projects that I knew about that have been completely put on standstill because of this the outbreak. So one of our specialist, he was doing his PhD with a focus in global surgery. So he was doing this ethnographic study on health-seeking behaviors of surgical patients. But obviously now health-seeking behaviors have completely changed. People don't come to the hospitals a lot because they think that hospitals are hotspots for COVID-19. So it's really difficult to gather data for a study such as that one. And a lot of other hospital-based studies as well have been put on hold because the admission protocols have changed, bed spaces are limited, and a lot of resources have been redirected to the COVID-19 fight. And I think even community-based studies have been really difficult to do, because I had a project of my own that I was going to do. I am part of the Clinton Global Initiative University 2020 cohort. So as part of my commitment to action, I am putting together a mobile clinic that would go into underserved communities and screen for chronic surgical conditions and non-communicable diseases. But at the moment, it is really difficult to go into communities safely. So my idea was to use that data to understand the burden of these diseases in communities, but we have had to put all of that on hold because we cannot safely go to these communities. So like Dr. Catherine was saying, I think going forward, we have to start thinking of alternative ways to carry out research and to think outside of the box for ways that we can recruit patients, assess them, follow them up. I think already during this pandemic, different ways have been initiated, but going forward, we can consider more how we can implement these changes in our low resource settings. I think that I will stop there for now. Thank you.
Thank you very much, Marcella. Before I invite Dr. Reviello to take over, I would like all panelists to think about the following question. If we have time at the end, we'll give you 1 minute to reflect on this. It's from Clovis. My question is a simple one, but probably without a simple answer. Where do we go from here? There's a lot of pandemic. There's a lot this pandemic is teaching us, and lots of gaps it has revealed, like Dr. Karikaze pointed out. But what actions can we take as students, as faculty, as instructors, as researchers? What can we do? Please think about this. As Clovis said, it's not going to be a simple answer, but we'll try to address it at the end. Back to Dr. Reviello.
Thank you, Prof. Bebe. And actually, thank you, Dr. Marcella. Your last set of reflections on the innovative work you were doing and how it was put on hold, innovative work reaching out to communities to collect data to understand patients' experiences, I think is the perfect segue into the last structured question, section 5. So I'm just going to read it exactly how we had it. I want to turn our attention to the future, to life after COVID-19, kind of that new normal whenever we get there. And ask our panelists, and I'm going to gear this question to Nelson and to Dr. Claire. So to ask Nelson and Dr. Claire how we can use the learnings from this pandemic to identify new innovations in medical teaching and research and opportunities within medical education that could, in time, benefit global health systems. So it really is carrying on from where Dr. Marcella left off. Nelson, would you like to take that one?
All right, thank you, Dr. Robert. I would quite agree very much with you that we have a lot to learn. Looking to the future, we have a lot to learn, and not just learning this time around. We also need to prioritize what works. So imagine in 50, 100 years to come, we'll have a system that faces something very similar to this, and then we'll be left with future doctors who in time past were not probably exposed with the essential clinical skills to manage such condition, starting afresh to develop methods to overcome the situation by then. So to my colleagues, I think this period, what we need more, this is to the medical students in general, what we need right now is resilience and adaptability to this particular condition. It's nobody really knows. There's a lot of uncertainty about this pandemic. So looking at that, I think there are a lot of opportunities coming up in the form of telemedicine and online-based lectures. Though we in sub-Saharan Africa, we might not be able to capitalize much more on the technical aspects of it. The number one being that most of our teachers are very busy, and then the technical aspects of it are so there are a lot of things to consider in the technical aspect of it, but it has not stopped. It has not stopped us from actually seeing it as a viable option. There are a lot of online courses. Presently, NIMSA Nigeria, which is the national body, Nigerian Medical Science Association, has developed something like an app that's called Lecturio, where students themselves have opportunity to create online course materials. They have videos, clinical cases, clinical scenarios, where they can meet and also discuss with themselves. So I think there are a lot of options are coming in from telemedicine, from web-based platforms, such as even Zoom, like this. And we need to exploit, but it comes with its own challenges also, in that there might be the problem of distinguishing between work and school environments. So it can be so difficult changing, adapting to the new platforms that are coming up. But we need to look deeply into it and then prioritize what part of it works. There are a lot of things to learn, but we need to prioritize a lot. We need to prioritize what works. So continuing from that, I want to state that curriculum should actually be reviewed. There should be a curriculum, or we should start developing a curriculum that is very, very detailed to training or making medical students and trainees very, very ready. I mean, for something like this in the future. We should look at developing a curriculum that is standard and recognizes that situations like this will always come, and medical students who medical students now, who are also doctors tomorrow, would be able to look back and then check what was done at a particular period of time, and then imitate and even work on that, so they don't have to start afresh again. Also, I would encourage that there should be more electives post COVID-19, so that it will allow for shared experiences for medical students. In fact, faculties should also share with the medical students, since the medical students are not themselves not in the hospital to see these things for themselves. So I think it will be a very nice initiative if medical schools all around the world could share what works best, or how they are managing patients with COVID-19 to medical students, the protocols, so medical students can follow through. It also calls for the need to check on what we really mean by professionalism. Professionalism in the sense that there's no recourse to the mental health issues of medical and young doctors. It has come to a situation whereby we need to look more at the health status of the doctor or the medical student before they come, because right now, if it's not about being a hero right now. a lot of people are, as there are so much uncertainties about this condition, I think we should look more into making sure that the doctor is all right before he can attend to the patients. So with that, I would like to cap it all with leadership. Yesterday, I was fortunate enough to represent the WHO Afro region in the InciSioN webinar, looking at global surgery and universal health coverage in the era of COVID-19. And Professor Emmanuel Makasa, I'll make reference to him, said we should start developing leadership skills so that in future, we have a set of leaders who have the leadership competencies to make policies and put policies in place that makes healthcare very easy to deliver to the people. In future, in future, if we don't look very more into this, in future we might have medical students who are not doctors then that have the clinical skills to deliver healthcare, but don't have the facilities to make sure that this healthcare is safe, affordable, and timely. So we need to look more into developing leadership skills in medical students. And as Dr. Catherine Chow said, she said that web-based platforms like this are very, very nice initiatives. It doesn't have to be physical platforms again. And I really want to appreciate this initiative by University of Global Health Equity, Lifebox and InciSioN. So it's a very nice one. There are a lot of things to learn, but we have to prioritize what works. Now, I think I need to leave the floor. Thank you very much.
Thank you, Nelson, for all those points. I particularly resonated with the need for and the opportunity to be consciously developing leaders through this time as we face the future. All right, and finally, Dr. Claire, would you like to?
Well, yeah, I think Nelson said a lot I wanted to say, but I will go back to lessons learned. And I think really, as I said, the COVID-19 surprised everyone, but taught us important things. Look at the education. Education will never be the same. I cannot count how many webinars I've attended to. I'll usually plan for 1 or 2 conferences a year. I will pay the flight ticket. I will stay maybe in a very expensive hotel. And, I will end up with 2 certificates. I have now, in 2 months, I have maybe more than 10 certificates. And when I go back, I look at the webinars I have attended. I have had the opportunity to listen to, very important neurosurgeons giving lectures. And the question I was asking myself, is it the same as when, I was attending these conferences live? What did it change? It didn't change much, because I will go to those conferences. I will probably not get even to meet them or greet them and talk to them, as Nelson said, but I will listen to them and I will listen to the lecturer. So it has been the same. It has been the same. And I wonder why we waited for the pandemic to start, having so much webinars. I don't know. But, we have them and we have to take the opportunity to use them and to use them very well. I've also, there's another neurosurgeon who developed a virtual OR. So he basically takes cases and through virtual reality, he will go into the operating, and you're assisting, you're seeing all the steps, and he has been recording video cases, and that's a very good way of teaching. And honestly, I've had cases where first, before going to do my case, I will watch one of the videos that is resembling my case and pick up some of the highlights he's telling us, and do my case and succeed in doing my case. So I think knowledge can be provided without having the presence of all those people who will travel to, to those conferences. We can still have these webinars and still give a good content and still have an impact on education. So the other thing I think we need to evolve to technologies. We need to include innovations into healthcare delivery. I think we have not been using our biomedical engineers, for instance. Recently in Rwanda, our biomedical engineers started looking into manufacturing homemade ventilators.
you know, it's a beginning project, but that's something that it's probably doable when they go into this and they collaborate with surgeons, they collaborate with doctors. And I also see the need in investing in critical care medicine and emergency medicine. This really showed, you know, the clear gaps in healthcare systems. If we do not have strong critical care, emergency medicine, then I don't think we'll survive any next pandemic or any other can be a sort of cancer coming and killing people, we don't know, and these people might need ventilators. I look at my field, neurosurgery, tightly depends on ICU beds, ventilators. You know, before touching any patient, I will make sure I have an ICU bed, and it's not always the case. So I see the pandemic as a good way of, you know, highlighting the need of including critical care medicine, uh, emergency medicine, and also, again, as I said, increasing our surgical services capacity. So it's a good way for global surgery, even if we have cases that are pending, but I think it has, you know, clear spoken for us. So I hope our leaders are going to invest more in this area, and I hope we will have, for instance, I was thinking about the patients I couldn't see because they live maybe in the other cities than Kigali. What if we had telemedicine? Of course, I called some of them, but what if we had telemedicine? I know in the US you use telemedicine a lot, and in other countries, but that could have helped. Maybe we could have had virtual consultations. So all those innovations in healthcare systems, in strengthening surgical services, critical care medicine, and in education, don't take the webinars as, you know, they're as good as conferences. I'm convinced they're as good as conferences. Thanks.
Wonderful, thank you, Claire. You know, to the point of the telemedicine, at least in my personal experience, it has been the COVID pandemic that has driven the feasibility of doing telemedicine at scale in the United States. I was never really using it before. It's just too complicated. And then with COVID coming, all of a sudden the systems were made much easier. That includes reaching out to the patients. It also includes some of the financial aspects and the billing. And so I feel like the pressure of the pandemic has finally driven this innovation forward. And I think it's another example of sort of call that you're giving us to use the pressure from the pandemic to drive innovation, and how we learned. The webinar agreed the access to information has increased, and we need to learn from this. I'm going to shift us now to the Q&A session. There have been some tremendous, thoughtful and important questions asked in the both in the Q&A box and in the chat box, and I'm indebted to Eric and Laura, who are on the backside, bringing some of these together. We've curated them. A number of these questions have been addressed in the comments throughout the time. Some further thought. So we have about 25 minutes, and we have about 7-8 questions. I'll try to move us through them. Many of these questions come from friends and colleagues in Rwanda, and grateful to virtually see all of you, to hear your voices through this path. And there are also questions from around the world in different places, so I'll try to get to all of them. I'm going to direct the questions to various panelists as we go through. So the first question, I'm going to direct this to Dr. Catherine, Dr. Mahalat. The question is this: how should specialists, surgeons, and anesthesiologists be intervened onto to support medical students who are passionate to run in surgery and anesthesia and obstetrics in their postgraduate amid this global pandemic that is also disrupting their mental health? So how can I think the question goes to, how can the faculty be supported to support the students to still pursue these dreams? Dr. Catherine, you want to start?
Sure. I mean, I think it's important for those of us championing the fields of surgery, anesthesia, and obstetrical care in sub-Saharan Africa to continue to push to do that amidst the COVID. I mean, the long game is still to try to entice and interest medical students into this field. And I think that's something not to forget about. I think that the way to encourage them first is to lead by example of how are we handling our own field within this pandemic. And I think some of those things would be, you know, to ensure that we still continue to push for access for surgical care, and then to really push that surgical care is a part of strengthening the public health care system. I think that, you know, up until now, we've been left out of that conversation. I think in the middle of the pandemic, it's actually a great way, if we advocate for surgical care, to be a key component of health system strengthening it. Because of all the things we've said already today, that you know, there's going to be a huge backlog of cases. The cases were already pretty limited, but you know, we contribute to a huge part of healthcare needs, and so I think that's a way to encourage medical students. I think the other thing to encourage medical students is that if we make the environment one in which it's safe to work in. So the lack of PPE, you know, has been a huge concern for frontline workers, but then obviously young persons thinking about going into medical school who are in medical school might think, well, perhaps I shouldn't choose this profession because it's dangerous. So I think that would be also important to try to ensure that we as societies, as groups, push for that. And then obviously the last thing is just to join that fight to get better testing capacity and rapid testing for sub-Saharan Africa. That's been a big political issue. You know, the supply chains, it's not that African countries can't afford the tests, it's that they're just not available to us because wealthier countries have sort of bought up a lot of the reagents and things. But I think if medical students can see that those of us practicing are pushing for all those, then hopefully they'll still feel that, you know, this is a field that they still want to go in. And I think that this pandemic has really shown that anesthesia and critical care, I think Claire mentioned that, is saving lives. And I think that, you know, that's a very noble thing. And I think that's something we can push as a positive.
Role model, provide hope, push for PPE, push for testing, push for critical care. Thanks, Dr. Catherine. Dr. Mohalet, what are your thoughts? Dr. Mohalet, you're still muted. We haven't heard you.
Sorry again.
Speak to, no problem.
Thank you, Rob. So just as it has been mentioned already, we have seen this pandemic as a great opportunity for our field, actually, for anesthesia and critical care, because in our country, it's almost a forgotten field. Most medical students don't even know what an anesthesiologist is, or that even an ICU deserves a special hospital by itself. So this was this is a tremendous recognition for our field. So not only for our field, actually, just in general, for physicians, it has been a great opportunity. It has been a great opportunity, this pandemic. It has shown a lot that the physicians are the new heroes of the country. It has given emphasis that we have to work on our hospitals, and we're getting all the encouragement from the society. We're getting encouragement from the government. The government is trying to put on incentives for the frontline workers. So all these things in general are a good incentive for bringing in these medical students, and even for our field, bringing new recruits into the field of anesthesia and critical care. Thank you.
Thank you, Dr. Mohalet. We'll continue recruiting and encouraging people in. Okay, this next question, I'm going to direct it to Nelson. So Nelson, this question, I believe, if I go back, came from students at the University of Global Health Equity. How can this pandemic be turned into learning opportunities? We've already started thinking about this and sharing with us the participant says, I think students need to experience the working conditions, like this. Do you think stopping clerkships internship is a good idea in that regard? Thanks. So how can we is this a good idea? I think we know your answer. And then how can we turn this into a learning experience?
Thank you very much, Dr. Robert. Actually, if everything were to be normal, in a normal scenario, I think medical students should be still we are part of the management team. Albeit we need a lot of we learn their supervision. We still need a lot of supervision. But where things were to be normal, things being normal, I mean, if there were to be adequate PPEs, there were to be necessary. The triage system is a protocol has been developed that is standard, and everything is put in place. Ventilators and all these things are there. I think medical students should be part of the clinical, management team. They should be part of the rounds, and they should help in also managing COVID-19 patients. But as it stands, no, it should not be allowed because we have a lot of restrictions. There are a lot of things to consider. Testing, are there enough testing? Are there enough PPEs? Are there enough ventilators? All those things need to be considered. Imagine what happens if just one student gets infected. Imagine the number of people is going to give along the way even by going home. Infects maybe probably other persons, his friends, colleagues, and so no, it's not possible. But there are other ways in which medical students can actually be very, very useful this period. We've seen it even in the past few weeks. Medical students have shown a lot of important roles. They've played a lot of important roles in leadership and coordination. The last students for COVID surge, that we had the global unification celebration we had for class 2020. And you've seen it in the intercollaboration between medical students, pharmacy students, nursing. They've even gone into the supply chain. Medical students are making clothes-based, maybe fabric mask. Some of them are even donating to government agencies. And aside from that, some of them some are volunteering for the health workers who are in the front line, and they are helping them to maybe get some supplies, helping them in various ways. You can imagine some of them babysit. So there are a lot of things we can do. There are a lot of things we can do this period. I think medical students should continue to show their role. We are not. I mean, we are not. We are useful this period also. So there are ways you can do it. But right now, to be in the clinic, no. Thank you very much.
Thank you, Nelson. It's a very nuanced answer of, yes, there's a way to be involved, and we need to be thoughtful about protecting students and their families, and the patients in the healthcare system. And yet there are remarkable ways that, just in your list, that I had not thought of, that students like you and InciSioN around the world has participated in. Great. Next question. This question I'm going to direct to Dr. Marcella. In some of your earlier comments, you talked about the disruption in teaching conferences, in morning reports, and the side-by-side learning and the face-to-face learning. This question, the participant asked, do you think the implementation of technology in medical education could be an unparalleled opportunity for medical students, and I would say for postgraduates as well, to start thinking how telemedicine and interprofessional cooperation could look like in their future careers? So in summary, you think what are the opportunities for future careers as students and postgraduates to use telemedicine, teleconferencing for their future career development?
Thank you, Dr. Rabiel. I think at this point, we ought to start thinking about these new innovations and new technologies. Most of us that train in, say, these parts of sub-Saharan Africa, we have been used to face-to-face learning and didactic lectures and things like that. But I think that the world is changing. And so even though this is really difficult in settings like ours because of resources, but we have to start thinking about it. I think there is a chance that we can actually sort of substitute face-to-face learning with like haptic stimulations and simulations, like Dr. Claire mentioned, this virtual surgery kind of thing. Like a few months ago, I downloaded this app, Touch Surgery, which is quite good. It's kind of like that. So you not perform the surgery, but it's kind of virtual and it's really interesting. So I think there's an opportunity for us to consider that aspect as well. I think virtual reality can be very useful in times like this, because we have seen that, well, in recent years, every few years, there's an outbreak or something that sort of like deters education and surgical training, medical students training. So incorporating technology would not be a bad thing at all. I think we can encourage like universities and training programs to subsidize or to make available virtual platforms for learning. So a lot of people didn't use Zoom before this pandemic. A lot of people didn't use any online learning platform before this pandemic. So I think that we can start thinking about things like that and ways to complement face-to-face teaching, or if the need arises, to sort of not abandon, but carry on with these technological advances. Thank you.
Wonderful. Thank you, Dr. Marcella. I think we've learned a lot, so much, and it's sometimes we think of Zoom and the telehealth platforms as our own location to somewhere far away, and it's allowing all of us to meet across 2 or 3 or maybe 4 continents. It's also allowed us to meet within hospital walls and still maintain our social distancing. So as an example, here at Brigham Women's Hospital in Boston, every morning at 7 o'clock, we gather to discuss all the trauma and urgent emergent patients. We use Zoom. And so there may be 30 of us or 12 of us on the call, but we're sitting in 6 locations. So I think there've been so many, and that maintains the teaching that happens around patient care. Okay, I'm gonna sneak in 2 more questions. So one is gonna be to Dr. Claire, and I'm gonna take the privilege of the microphone to send a question to Prof. Abebe after that. And then there'll be the final question for all of us that Prof. Abebe had us think about from Clovis. So this question to Claire was directed to you already. I just wanted to ask my question to Dr. Karikaze. To the patients in sub-Saharan African countries who need medical care from outside their countries, how are they being helped to travel since many countries are in lockdown? Also, the questioner appropriately asks if anybody else on the panel has thoughts on this or experience. Claire, I don't know if you have thoughts on this.
Well, okay, so that goes with what I said before about strengthening our healthcare systems. Think about this. You have trained surgeons, you have built the capacity, but that capacity lacks, for instance, some equipment to function. So with the pandemic, what have we seen? So those well-trained surgeons, those good hands, are unable to do something, for instance, if they do not have equipment, if they do not have ICU beds. So those patients, unfortunately, will not be able to travel with the pandemic, and they'll be here and we're facing them. So what is teaching us is we need really to invest not only in building the capacity, but in having our own equipment, having a sustainable way of maintaining those equipment, having enough space, because it's not only having the equipment, but how many ORs do you have? How many surgeries can you do? And the system needs to understand. So it all goes with the 4S, really. You cannot increase the number without increasing the equipment, without increasing the space. So you have a surgeon, give him the equipment to work, but give him the space where he can work. And then you will see all those patients, they will not need to travel to get treatment outside. That's my belief. I believe we have good brains, good hands of surgeons, and they just need to be supported. They just need to be understood. When I say neurosurgery tightly depends on ICU beds,
maybe before the pandemic, no one will really understand what a ventilator means, what an ICU bed means. Well, it means someone will not probably be briefing on his own. I need him to have a tube for maybe 1 or 2 days, and then he can be extubated and he'll be okay, and I can operate on him safely. So that's a very small nuance, and I think we need to invest in that. We need to invest not only in people, but in equipment. And what if we buy those ventilators? That's another issue. We buy them, we bring them, we do not have enough critical care doctors, we do not have enough anesthesiologists, and those people or technicians, they cannot repair them when they're broke. So we are losing in any case. So we need to think brightly, we need to think more profoundly and see, okay, we can bring all those innovations. I know we're talking about innovations, but how do we maintain those innovations? How do we maintain them? We have to have a maintenance system behind, because otherwise we're losing in any case. I think that's my comment about that.
That's terrific. So we're in a pandemic. Other pandemics are likely to come. There'll be other lockdowns. The solution isn't figure out how to move patients out of your country, but to develop the staff, the space, the systems, and the social support so people can get care where they are. There have been other amazing questions, Anissa, Ife, Fred, that I can't get to. The last question came in a while ago from Ajit Abahuje to Prof. Abebe. As a response to COVID-19, there have been strong cooperations between academicians from developed countries and those in LMICs. How can we maintain the efforts and the training and teleconferencing resources that were mobilized during this response to the outbreak to support health professions educations in LMICs? What support will medical students need to be able to benefit from those resources?
Thank you, Robert. I think this is a great question. What COVID has shown us over the past 4 months is that, number one, we were not prepared for such an event, a catastrophe. We were so used to the traditional way of research, teaching, and service that this caught us by surprise. That is why many undergrad medical schools in the region are completely shut down. A significant number of residencies are struggling. Exams are either cancelled altogether, postponed, or restructured significantly. It's only a handful of institutions. I can cite my own university, University of Cooperative Equity, that already invested a little bit on IT infrastructure. So with a bit of hiccup, we managed to put our 2 feet on the ground and start teaching online. This needed the resilience, the will, and the cooperation of our 30 students, really bright students. So number one is you have to believe that this will continue. If it's not COVID-19, it will be COVID-25. We need to be prepared. Academics as we know it has completely changed. The good news is that we don't have to reinvent the wheel. There are lots and lots of supporters out there who are willing to support us. There is a lot of material out there that we can adopt. We are really open, ready to learn in any way possible in Africa. So if we combine the willingness of our students, the readiness of our students, the new generation, the willingness of the faculty we have, our own commitment to invest in infrastructure, a little bit of infrastructure, and use the resources already out there, the partners we have, then we can move forward. We don't have to reinvent the wheel. The content is already out there. It's a question of thinking about this together, understanding the situation, the pandemic, the catastrophe is here to stay. I'm glad Nelson talked about leadership in the middle of the discussion. Leadership from both the academic side, the student side, and from the global community is really mandatory here. How do we use the limited resources we have together? Because at the end of the day, we are trying to produce doctors that can satisfy the significant, even I can't even talk about numbers here, the deficiency of the surgery, anesthesia, and obstetrician number here. So my short answer is there is a lot of support out there. There is lots of partners out there. The ball is now in our court. Thank you, Robert.
I think with that, we will transition right back to you, Abebe, for closing remarks and thanking all our panelists.
Ladies and gentlemen, you have been tuned to a virtual webinar hosted by the University of Global Health Equity, Lifebox and InciSioN. The past 90 minutes have been fantastic. We have been joined by 5 great panelists from the region. And this webinar was hosted by myself and my colleague, Dr. Riviello. Thank you very much for joining us. Before I conclude, the key messages from this discussion has been COVID has hit our healthcare service, our academics and research very hard. And surgery is no different. Our undergrad programs are almost gone. Residencies have suffered a lot. Examinations have been changed significantly. Most research, particularly community-based activities, have been cancelled. And trainees, trainers are really worried that their families are in danger. Things they haven't seen are coming their way. And the mental and psychological issues are a real threat to all of us. We have also heard that some trainees are even delayed for 1 year because exams cannot be arranged. However, this can also be seen as an opportunity for us to create research collaborations, innovative research collaborations, to strengthen our infrastructure and get engaged with virtual meetings, webinars. There was even mention of virtual theaters and virtual consultations. And the role of medical students in this, particularly InciSioN takes the lead here, is huge in terms of leadership, community mobilization, education, and advocacy. And there should be a way where we can compile the lessons we learned from this pandemic so that we can take the message forward. I would really like to thank all of you for joining us. I would like to remind all of us that this session has been recorded and that the video will be ready and distributed to all of us within the coming few hours. Until we meet again with a similar webinar, on the behalf of my co-host, Dr. Robert Riviello, and the partners, UGHE, Lifebox, and InciSioN, I'd like to say goodbye and say farewell. Hope to see you again next time.
Thank you all.